press anywhere on the screen.
And I'll be a cat wait feedback to you.
Green, probably.
Green, yeah. That will have to stick here?
No, you go up there to stick.
Yeah,
The
that's what I
camera's there.
Yeah.
And this-
I wanted to all this because of all the paper and stuff. So
No, I could hear.
a bit easier to sort, but this, I just have no idea where it's from. We don't even have a well, hopefully it changes. Donna was promoted for 12 hours. Is this just the papers? Yeah. You're right.
Thanks. If it was anybody else, I wouldn't have done it, but it's because it's her.
It was a nice do last night. Is that? It was lovely.
They've been
Nice.
it's a WHO initiative. Beach friendly city.
As I said, the fact
Yeah.
not when I hate someone else,
Yeah,
but when we
that
aspect when
in
the guys.
Well, no, actually, they moved the aging. Well, the aging
Still
was
further than 2 minutes. So very, very
aging
positive.
cities.
I knew that
Making them-
Okay, back to, no, it's in Geneva. Well, I know, I've followed it since I was. No, it's interesting to me.
We are a-
Doing the thing you're doing.
for example,
You listen on the radio.
Hmm?
No, you're not even listening.
Like, I'll just get in. It's all right.
Oh, yeah. I don't, well, now they go up right away.
Good
Saying,
morning.
I was here. Yeah. And then the world did it.
Morning, everyone. Thank you so much for coming in person. We're so excited to welcome you to the 10th Festival of Public Health. And we're so pleased to see so many of you here. So my name's Alpana Verma, and I have the great privilege of leading our team of researchers and teachers and professional staff who make this happen every year. And we're really pleased to say that we've got, I think, the best line again this year. So really pleased to see. I do have to apologise and take personal responsibility for those of you that were expecting Sajid Javid. As you know, a week is a long time in politics, and unfortunately, things didn't work out according to plan. When the herd moves fast, they move fast, and then are the brakes, as a man once said. And so we have lots of interesting talks for you, but I'm sorry to start off with the housekeeping. We're going environmentally friendly, so hopefully you'll see the QR codes. This will link you up to the programme and also the ability to provide feedback. Fire alarms. There are no practice alarms. So if you hear an intermittent alarm, that's just get ready. In all of your rooms, you will have members of the team that will show you to the nearest fire exit. And if it turns into a continuous alarm, that's when we will be going outside from both this floor, which is C floor, which is the floor that you came in on, and then B floor, which is here, to the muster points, which is on Altrincham Terrace. We also have CPD certificates for those of you who need it, and we have points from the Royal College of Physicians. Please just email. Please take time to look at the exhibition areas and the parallel sessions. Chairs, please keep to time. Feedback forms, please have a look at your programme. We've got posters during lunch, and we are tweeting. Please do tweet, and photography. They've got some lovely people who are taking photographs, but please do tweet using hashtag PHFest 2022. And food, if you've got any allergies, the information desk will help you with that, but everything will be labelled for you. And if you are able to stay, we'd love to invite you to our welcome reception for the speakers at 5 o'clock on B floor, and our barbecue there. Here's our team, and they will be available throughout the day. Please ask us. Remember, the code is available for you. And just a quick rundown before I hand over to our Dean, but we have rebranded ourselves into the Department of Public Health as we've been growing over the last 10 years. And some of the key things that I hope you'll be able to come and talk to us about is our work on inclusive research. And this includes looking at where service provision doesn't quite match. We've also been working across the board, and I'm so pleased that Obo is here and Siddharth, and looking at different COVID projects. We've also been working nationally on the Protect study. And again, please have a look at your programme if you'd like to know more. And Liz is here, Liz and Steph, who've done fantastic work with our ICU multidisciplinary team. And this has gone out thanks to Lauren at the faculty to different railway stations to look at how we can help with the post-COVID response. We're really pleased that our master's programme is going from strength to strength, and not just having the master's programme. We've decided that we really needed an undergraduate programme, and Lindsay and the other members of the team are here to answer any questions on teaching, together with our open access courses. We can't forget what's been happening, and for those of you that have been affected by the weather, you'll know that we've had a mini heat wave during the last week. So next year, we're proud to announce that we will be doing climate change and environmental public health. So again, remember the QR code, and without further ado, I'm going to hand over to our marvellous Dean, who has supported the festival for the entire time he's been with us. And we're so pleased to welcome him to the 10th anniversary. Thank you, Graham.
Thank you very much, our partner, and welcome to all of you. And thanks for coming here either face to face or online for the 10th International Festival of Public Health here at the University of Manchester. And as our partner was saying, fortunately the weather this morning is a bit more like a typical Manchester summer day. The last week's been very strange. Hopefully we don't see too many more of those types of temperatures, although I fear that we will. And so the fact that you're doing climate change next year is absolutely fundamental, because it will impact every aspect of public health going forward. So my name is Professor Graham Lord, and I'm the Vice President and the Dean of the Faculty of Biology, Medicine and Health. And I'm pleased to say during the last 10 years, so it really is a fantastic 10th anniversary, the festival has hosted, I've got some notes here so I'll get the numbers right, over 5,000 delegates, 200 stalls, 800 oral presentations, 50 workshops, 300 poster presentations and 20 plenaries, which is extraordinary. The last festival we hosted in person was in 2019, which seems, it's only sort of 3 years ago, seems a lifetime ago in the blink of an eye in many ways. I think, and we're all still processing what happened and what is still happening. But it's been a really big 3 years. Our partner mentioned some of those. I'm sure for the rest of the day, you're going to be talking about what's happened in public health over the last 3 years. So there's a fantastic program that you can access through the QR code, whether you're a student, a healthcare professional, from an NGO or an interested citizen. I think there's a very broad church we have in the audience, which is fantastic and exactly what you need to address the core challenges of public health going forward. So everything we do here in Faculty of the Biology, Medicine and Health is to have an impact on public health locally, nationally and globally. And it's just a huge team effort. And all of our success relies on the collaborative efforts of our colleagues, our local authorities here in Manchester, government organisations, NHS and industry partners, and our patients and families within our local communities. And the significant contribution of all of these people help us to transform lives by being at the forefront of discovery, learning and translation, which is the motto of our faculty that we instituted in 2019. It's really great to see that being lived out in real time, which is why I've been such a strong supporter of this event since I started. So the University of Manchester and this particular aspect of our research, we've long been recognised as a research powerhouse. And I think the university has research strengths in cancer, in the broadest sense, dementia, mental health, complex health needs in age-related and chronic diseases, immunology and tackling health inequalities. The list does go on. I think it's one of the strengths of the university that we do have a breadth of excellence, because no one particular discipline area can challenge the huge problems that we face now and into the future. I think I would particularly highlight the role that we played in the COVID-19 pandemic, establishing a COVID-19 rapid research group and working in collaboration with our NHS colleagues, utilising all of our experimental and translational expertise through our Biomedical Research Centre. And through this particular Centre of Excellence, we were able to fast-track research, innovation and treatments to minimise lives lost locally, nationally and globally. A lot of the public health COVID work that we did in Manchester, I know our partner and others were personally involved in this, fed into SAGE working groups, particularly around care homes and domiciliary care. And I think the impact of that will continue to impact how we look at research in care homes and in the broader social care aspect, which is going to be even more critical as we move more care out of hospitals and into the community. The Department of Public Health that our partner mentioned is part of the Epidemiology and Public Health Group, in the Division of Population of Health, Health Sciences Research in Primary Care within the School of Health Sciences in the faculty. And this sits at the heart of the Academic Health Science Centre at the University of Manchester. So there's real total alignment from all the way through from the faculty and the university out across the whole of the conurbation of Greater Manchester, and then with national and international impact. The Department of Public Health performs high quality research, delivers teaching and training in the field of public health, and has established links to local, national and international public health organisations. And I've mentioned just a few. With regards to our teaching, our partners already mentioned our hugely successful master's programme, which has tripled in numbers in the last 3 years. And I'm sure it will continue to triple every 3 years. And also the new BSc launching in the next academic year. And this is the first time we've had an undergraduate course in public health, which actually reflects the faculty's support of this important and growing area. And I'm sure that's going to be as much of a success as the master's programme. All of our teaching programmes offer an innovative approach to learning, meeting the training needs for health professionals that are interested in a career in public health or those seeking new skills in the area. Most of our students complete the programme part-time whilst working in a wide variety of jobs and sectors. And we've now got over 2,000 alumni from our postgraduate courses. And they're very good at keeping us informed of their huge successes back in their own countries, from influencing policy in their own countries and non-governmental organisations. And I think our alumni, Manchester, because of its size and its scale, we have 500,000 alumni across the world. So it's a massive opportunity for us to influence and work with countries all over the planet. And every time I give graduation speeches and talk to our students, it re-emphasises the importance that universities have in being global organisations in a time of increasing nationalism and factionalism. And actually public health is probably the most important area in how we can impact lives across the globe. So the brand new BSc in Public Health is aimed at applicants from home and around the world who are interested in a career in public health. And actually we're the only Russell Group university to offer an undergraduate programme in public health. And we're utilising our expertise in online learning blended with face-to-face teaching. And again, the Russell Group, as you all know, are the research intensive universities in the UK. So the fact that we're the first and only doing this, again, reaffirms our commitment to this very, very important area of research and implementation. And not only do we strive, and I think this is a very good example of this, not only do we strive for research and teaching excellence, like all universities, but we also have a third and unique goal around social responsibility. And in the faculty that I'm privileged to lead, social responsibility is embedded in our research and teaching through our Centres of Research Excellence, our teaching programmes, preparing our graduates for the future to improve the health and well-being of society and transforming lives. And consequently, last year we were delighted when we were ranked first in the world out of more than 1,200 universities in the Times Higher Education Impact Ranking, this year reflecting our actions towards the United Nations Sustainable Development Goals, the SDGs. And in fact, the latest table came out, we maintained that sort of top 10 position. And again, this is becoming increasingly important to universities around the world about how we evidence that. And we have to do it by delivering, not just talking about it. And I think Manchester has done a great job. And we continue to work with universities around the world as we seek to change the mission of how universities view themselves as actually having social impact and having global impact. It's not just about league tables. They're an output of what it is that we do. So our goals are absolutely enormous. Manchester's always been very ambitious, and we're getting even more ambitious, which I think is appropriate. I don't think it's unfounded ambition. And we seek to tackle huge challenges, such as transforming cancer care through initiatives such as the Kenya-UK Health Alliance that we set up 2 years ago. And I had the privilege of giving a keynote address at the House of Lords on Tuesday, telling other partners around the UK and from Kenya and East Africa about the work that we're doing there. So we are having global impact right at the moment. There's also enormous work in India and Africa that you've heard about today with work on COVID and also PrEP for HIV prevention in sex workers. And actually what this is all aligned around this annual Festival of Public Health, where all of this comes together and we celebrate it, but more importantly, we plan what we're going to do for the next year and the next 10 years. So that when me or somebody else in 10 years time saying it's the 20th anniversary, we'll look back and think, gosh, we did a lot in the first 10 years, but we did even more in the next 10 years. And that's my challenge to you. So you can invite me back when I'm, in in my dotage, and you can tell me what you've been doing over the last 10 years if it isn't actually me still here. So the goal of the festival is to bring an affordable platform for people from civil society to mix with academics, policymakers and public health professionals. And this year's festival has two main themes, really important themes: ending violence against women and children, time for change, and urban health. And we've got special sessions and keynote talks about these subjects, but we've also got many more topics being discussed throughout the day. And we hope that you'll benefit from the wide variety of sessions that we have on offer. In fact, I'm sure you will. And if I didn't have a whole lot of board meetings to chair, I'd love to stay here and listen to all of them. So I feel very sad that you're going to be the ones having all of the fun. And I'll be going off running boring committees, because actually this is what it's all about: doing the research, making the difference and discussing what we do. So finally, to finish, I'd like to take the opportunity to thank all of the speakers, presenters and online participants, including the Burning House Choir and Haylo Theatre. Thanks also to all of the chairs and the organising committee. And finally, I'd like to acknowledge Kay Marshall, who will be here this afternoon, who's the head of School for Health Sciences that Public Health sits within, who is receiving the Lifetime Achievement Health and Wellbeing Award for her work in women's reproductive health. So congratulations to Kate in absentia, but I'm sure you can all congratulate her later in person. So just to finish off, thank you very much for coming. It's great to be back here in person and online in a very blended hybrid model. And I hope you have a fantastic day. I'll leave it there. Thank you very much.
Thank you, Graham, and as ever, so grateful. But
Thank you.
thank you for looking after us at the board meetings.
Exactly.
So, as Graham said, we've got lots of excellent speakers. We hope that you'll take the opportunity to go to each of the sessions. We have very special permission, as sadly this area is going to be converted into our new innovation district. So this building will cease to exist as of next week. So we're actually allowed to bring drinks and food into the lecture theatres and into all of your parallel sessions. So please do have a look, both here on C floor and down here on B floor. There's lots of refreshments for you. Because we are tight in time and because we have got so much going on, we will be making sure that you can take refreshments in with you. So we don't want you to go hungry and we don't want you to be thirsty either. Rolling teas and coffees, water, orange juice, whatever you need, we've got it. And so just going to hand over to our next speaker. Joe, are you okay coming on? And can we just make sure we've got a sound check for you? So thank you, Joe, for coming across. So Joe has very kindly come from the World Health Organization, and we're so pleased to have him here because of the fabulous work that he and WHO and all the country partners have been doing on the eradication. And I'm sure many of you will have seen the headlines that we detected polio in our sewage in London earlier this year. So it's a topic that's really important. So Joe, thank you ever so much for coming. Yes, I think this. Thanks.
Thank you. Good morning, ladies and gentlemen. I'd like to start my presentation
by sharing with you this photo of two incredibly cheeky monkeys. Healthy, happy, well, except for the tantrums, energetic, mobile kids, very cheeky, especially the little one on the right. Abigail and Vivian are almost 5 and 3, respectively. Both are fortunate to have access to undisrupted healthcare services, including immunization, clean water and sanitation, clean living environments. If there are any health needs, mum and dad can just whisk them down to the clinic down the road. So sounds pretty good, and for us, pretty standard, right? I'd now like to contrast this with an image of an older image of Ruska Khatun from Calcutta in India, pictured here with her mum. Ruska, who I'm sure is equally as cheeky, is from a poor, marginalized, underserved minority community. She contracted polio, and this greatly affected not only her mobility, but her prospects in terms of education and work, general societal inclusion, and marriage. This should not have been the case. Everyone, no matter where they live, has a right to be protected from polio, even in places with little to no infrastructure. So it's a pleasure to be here with you today to speak to you on global efforts to eradicate this crippling disease that has been around since antiquity. My name is Joe Swan. I'm a communications officer for WHO based in Geneva, Switzerland. Prior to working in Geneva, I was working in Amman, Jordan, as part of regional Syria crisis response efforts and regional polio eradication in that area. I've been fortunate to have traveled with the job, and it's great to be here with you today to share some of these experiences with you. So thank you for having me here today. And just to clarify, the cheeky monkeys on the first slide of mine. So to start, let's look at the disease itself briefly. Then we'll get to the vaccines, where we are in terms of eradication. And I'll show you some field pics, which I feel do a good job of illustrating the work. Poliomyelitis is a highly infectious virus, mostly affecting young children. Disease mostly affecting young children. It's caused by the poliovirus that can attack the nervous system and can lead to spinal and respiratory paralysis, in some cases death. In paralytic cases, it mainly affects the limbs. Polio has been around since prehistoric times. You'll see the picture on the left. It's a picture from ancient Egypt, where a depiction of someone with a condition characteristic of the disease is shown there. So it's been around for a very, very, very long time. Only 1 in 200 cases of polio actually show symptoms, but asymptomatic people can carry and shed the virus in their stool. And this leaves under-immunized children susceptible to infection. For this reason, 1 case of polio constitutes an outbreak. As you would well know, most of the world has gotten rid of polio, but so long as it circulates anywhere, it's a risk to kids everywhere. We saw very recent evidence of this, of course, with detection of poliovirus in London through sewage sampling. And this is it serves as a stark reminder that, yeah, as long as the disease is still around, it will keep rearing its ugly head in all places. So to be clear, the detections in the UK don't constitute an outbreak. The UK Health Security Agency is taking preventive action, however, and moving to ensure kids are caught up on their vaccinations, which is very smart. They're also stepping up surveillance for polio, which also needs to be done. And here are just a few headlines, just reminders from the last few weeks, I would say a couple of months. I'm sure you saw many of those. Okay, moving on. The virus is transmitted fecal orally. It infects and multiplies in the intestines. Needless to say, then, this epidemic-prone disease thrives in areas where there is poor sanitation and also diarrheal diseases. Weak health systems is also a crucial factor. Substandard immunization, poor infrastructure to administer and maintain vaccines, poor surveillance, to adequately pick up signs of the disease, etc. In countries where there is conflict and insecurity, there's always almost compromised access to vaccination. When the Syria crisis started, for example, plummeting immunization rates, which were historically very high, allowed polio to regain a foothold in the area and paralyze kids. It then moved to Iraq as well. Suddenly, countries that hadn't seen polio for, say, 10 to 15 years were seeing cases. Another example of compromised access is, of course, Ukraine. Polio was first isolated in Ukraine in October 2021 in a little girl who developed acute flaccid paralysis, which is a major indicator for polio. And in January this year, a second case was found. The virus is linked to Pakistan, and it also affected kids in Tajikistan as well. Other examples include outbreaks in Nigeria, particularly in Borno State, which is inaccessible. A lot of areas are inaccessible for vaccination. And an explosive polio outbreak in the Horn of Africa in 2013, in which Somalia was really badly hit. Yemen is also a very current example of this issue. All this to underscore that in places where health services are compromised or disrupted, most often in places with political upheaval, conflict, we should be on high alert for diseases like polio. Now, just a historical photo here. We've come leaps and bounds in the battle against the virus. But in the 20th century, early 20th century, epidemics were frequent. And this is equally so in industrialized countries. Here's a photo from the 50s showing iron lungs to help kids breathe in a polio ward in the US. This was before the development of an effective polio vaccine. The good news, the virus is preventable and eradicable. Not only are there 2 safe and effective polio vaccines, but vaccination against polio generates herd immunity, which of course increases the percentage of the population protected. Polio has no natural reservoir, and without human hosts, it can only survive in the wild for a limited period of time. And most infected people only shed the virus for a couple of weeks, so this is a limited time spent. So these factors render the virus eradicable. In fact, 2 serotypes of polio have already been certified as eradicated. Type 2 was declared eradicated in 2015 and type 3 in 2019. So the only one left is type 1 in endemic Afghanistan and Pakistan, who have never stopped the virus. The virus has been confined to these 2 countries for a long time now, but we recently saw importation of WPV1 into Malawi and then Mozambique very recently. Now, just to note that this slide only shows the wild virus. There's also what is termed vaccine-derived poliovirus types 1, 2, and 3, with type 2 VDPV being the one that was picked up here in the UK. I'll get to talking about VDPVs in a minute. On the vaccines, I'm sorry I'm going fast. I've got a lot of notes and I want to make sure I get through them. But there'll be question time later, so if anyone has any questions, please save them. On the vaccines, so there's 2 categories of vaccines for polio, as I'm sure a lot of you know. We've got oral polio vaccine, which is still used in many countries around the world. There's also inactivated polio vaccine. Both provide immunity, but in different ways. So OPV is a live attenuated vaccine, and it confers gut immunity. It can confer gut immunity, whereas IPV cannot. So OPV stops polio from multiplying in the intestines, therefore stopping the virus from being transmitted to another child. Interestingly, OPV can also offer passive immunity in places where the virus is excreted. If other kids come in contact with the vaccine virus, it can passively immunize them. IPV, on the other hand, is an inactivated vaccine, and it offers blood immunity, but doesn't stop the virus in the intestines. So, although you may have been, you probably have, I'm sure you have been vaccinated against polio with IPV, you can still carry the virus and pass it on, but you won't be, you won't suffer the symptoms of polio. Now, getting to VDPVs. Oops, I'll stay here for a second. Okay, so OPV is used in many countries globally still because it stops transmission, it offers passive immunity, it's cheap to administer. You don't need a trained health technician to give a shot. It's just 2 drops in the mouth of the child. And in places with little to no health infrastructure, you need to work with, this is a good tool to work with. OPV has been the workhorse of the eradication effort, having brought down cases from by 99.9% from 1998 until now. So it's been instrumental to bringing us to the brink of eradication, and it's very effective. In rare instances, however, in places with low levels of population immunity, the vaccine virus, after being shed, can pass around in the community and undergo genetic changes. And after a period of time, the series of genetic changes can lead to what we say reversion to neurovirulence. So that's to say the vaccine virus, if it continues to find unvaccinated hosts, it can revert and lose its attenuation and regain its ability to paralyze. Evolution of the OPV vaccine virus into VDPV is, strictly speaking, a rare occurrence, but in the past few years, we've seen a lot of these cases spread, particularly type 2 VDPV. And it's a major challenge for the global polio eradication initiative. Incidence of CVDPV2 is due to a number of factors, including waning mucosal immunity to type 2 virus, delayed detection and response times, and suboptimal immunization campaign quality. As I said, this only occurs in places with weak immunization or with poor population immunity. And while it may sound counterintuitive, the only way to stop an outbreak of vaccine-derived poliovirus is with the vaccine itself. Enter NOPV2. So this is a large part of my work at the moment. So part of the strategy to bringing these circulating vaccine-derived poliovirus type 2 outbreak, CVDPV2 outbreaks to an end is using this tool here. It's also tightening gaps in immunization planning and response. So this tool, novel oral polio vaccine type 2, has been used since March 2021 to combat CVDPV2. It's a modified version of the vaccine that was previously used to counter these outbreaks, but it has the advantage of being more genetically stable. Therefore, it's less likely to be associated with emergence of new VDPVs or seeding. To date, 21 countries have used the vaccine, and I think we're at 450 million doses administered currently, so almost hitting 500 million. How are we tracking? So I talked about the disease and the vaccine. What about progress? So in 1988, when the GPEI was established, wild polio was endemic in 125 countries, approximately 350,000 cases worldwide. This has been brought down. In 2021, only 2 endemic countries and only 5 cases, which is the lowest ever in history. So that's a massive reduction in cases. However, as I mentioned, we've recently seen more circulation in Pakistan, in particular, and importation of the virus into Malawi and Mozambique. This slide here shows wild poliovirus and CVDPV, predominantly type 2 CVDPV cases over the past 6 months. You can see Afghanistan and Pakistan in yellow there. There are 2 endemic countries, a bunch of countries in Western and Southeast Africa, also with cases. And we see that the line represents the importation of WPV1 into Malawi. Who is behind polio eradication? So many partners contribute to the progress. GPEI is a private-public partnership, the biggest in the world actually, comprising WHO, UNICEF, Rotary International, the US Centers for Disease Control and Prevention, BMGF or Bill and Melinda Gates Foundation, and most recently Gavi. We work with governments, donors, volunteers, NGOs, the media to get the job done. It's truly a mammoth effort to reach every kid in the world with vaccines against polio. So GPI started in 1988 after there was a World Health Assembly resolution to eradicate polio, and this came after smallpox eradication. Bringing me to the point that eradicating a disease is a very costly endeavor. This year, GPI published its new strategy for 2022-26, and this looks at sharpening the approach to the getting over the remaining hurdles, strengthening health systems in affected countries, and to deliver a polio-free world. It focuses on two overarching goals, and these are stopping transmission of wild poliovirus in the endemics, and stopping transmission of CVDPV and outbreaks in non-endemic countries. So essentially, it looks to amplify efforts in the highest risk countries, and it includes a lot of innovative tools and tactics, integrating polio services with other health services, rollout of NOPV2, as I mentioned before, managing vaccine information, misinformation, or disinformation, building stronger relationships with their communities, and better engagement with communities. Also strengthening the programs, partnerships with governments and supporting actors, and tightening campaign operations. A large part of the work is also gender equality, and GPI is committed to achieving this and mainstreaming the empowerment of women at all levels of the program through its work, recognizing the importance of gender as a determinant for health, but also the driving force of women in the eradication effort. Oh, sorry. Just get back. Also recognizing the immense value of the polio infrastructure and to support health systems. And this became very apparent during COVID. I mean, GPI has been supporting, the polio program has been supporting other health initiatives where it makes strategic sense to do so for a long time. But COVID really shone a light on this. We've got 30,000 polio staff currently supporting COVID-19 efforts, vaccine rollout, outbreak response, training, preparedness coordination, risk communication, data management, reporting. So it's not just a one-track effort. The strategy comes with a sizable funding target of 4.8 billion, and GPI will be holding a pledging event this October in Germany to try and raise that. It's a lot of money, but we sincerely hope that donor governments can come back to the table to help us get the job done. Because as I mentioned, it's not over anywhere until it's over everywhere. And eradicating polio doesn't just make humanitarian sense, it also makes economic sense. More than 18 million kids are walking today because of efforts to eradicate polio, and what an effect that has had on lives and livelihoods. And if we don't stop polio, we could see the disease roaring back with upwards of 200,000 cases after 10 years, per year after 10 years. So it's highly cost effective, and it will save the world buckets of money if we can actually get the job done and finish it. We're so close. And yeah, we're hoping governments can come back to the table. UK in particular has been a great supporter of eradication for the longest time. They had to cut funding considerably recently, so we're hoping the UK in particular can come back to the table. Okay, just very quickly, I'll want to run through some photos from the field, just to give you a quick idea of how the job's being done. So detection is done through two means. The gold standard for poliovirus detection is acute flaccid paralysis surveillance. So when a child presents at a clinic or is found with symptoms of rapid onset paralysis, there's a case investigation and stool sampling will take place in addition to lab testing. Lab confirmation is the only way to confirm or rule out polio as a cause for the paralysis. And here we'll see a little girl, she's unable to place any weight on her left leg. Another method for detection is environmental surveillance, and sewage samples are regularly monitored for the presence of poliovirus. This helps us cast a wider net for detection. And I mentioned that only 1 in 200 cases is symptomatic. So this helps us find it, traces of polio in the sewage. I'll skip through these fairly quickly, mindful of time. Here's a physician testing reflexes in Pakistan. This is environmental sampling in Nigeria. Stool samples are sent to labs. From there, they do they test for the presence of poliovirus. They determine type of poliovirus and whether there's a genetic connection to other polioviruses to find out where the virus came from and where it's going. Next one. When poliovirus is confirmed, we mount an immunization response. So then we have repeat mass vaccination campaigns using OPV to reach kids under 5. Generally 2 rounds of immunization response, achieving 90% or above coverage should be enough to stop circulation. We also step up environmental surveillance and AFP surveillance during that time and try and enhance routine immunization services where possible. This lady's planning out a campaign. She's got to map all the kids in a particular village. There's households for the micro plans, and there's also significant logistical things to be planned. Just very quickly, there's a truck moving over anti-government element-held territory in Syria. So it's not as easy as just popping down to your local GP to get your vaccines. This guy's a machine. Afghanistan volunteer vaccinator carrying cool boxes, taking it to his mates to distribute polio vaccines to kids in the village. About the same age as many of you here. Okay. Women in particular are a driving force behind the eradication effort. They enjoy the trust of communities, especially older women. They can access the households where oftentimes men can't. So this is a cultural thing that makes it particularly important to have women at the doorstep. Driving force. I'll just skip very quickly through these. This is a favorite shot of mine, the donkey shot. We transport vaccines by any means. This is transit point vaccination, particularly in Afghanistan, Pakistan, where the borders are very porous. We make sure we're reaching kids on both sides of the border. Going through floodwaters in India. And it's really remarkable when you speak to vaccinators, they're really proud of their work as being guardians of health. They're amazing people. And I'll end there with, this is a shot. I took this in Sokoto in Nigeria. I particularly like this photo. So this is an area experiencing a CVDPV2 outbreak. And we managed to stop circulation there. And Nigeria is still seeing outbreaks. It's actually one of our hotspots at the moment, but hopefully with the rollout of NOPV2, we can stop these outbreaks more sustainably. I'll stop there. Thank you very much. And I hope if you have questions, please come and see me afterwards, or I think we'll have a Q&A later. Thank you.
I think so.
Thank you so much. That was really something. Yes, we could have from you for much longer. I'm so sorry we had to go.
No worries.
Thank you very much. So, as you know, one of our themes this year has been urban health, and I'd like to ask Joe to come up to talk for our next speaker. Joe needs no introduction. For all of you that have followed urban health and I think they're knocking it down. She needs no introduction because Jo has been a founding member of the International Society of Urban Health, as well as being a friend of the festival from the beginning. And we were so pleased that Jo was president when we hosted the International Conference of Urban Health in 2014. But Jo, we're so pleased to have you back in Manchester. Thank you so much.
Good morning, everyone, or other time zones that are watching us virtually. It's a real pleasure to be here at the International Festival. I would never say no to Arpana Verma and her team. As she mentioned, in 2014, they hosted our global conference on urban health, and she began the urban health section of the European Public Health Association, which she was just telling me this morning started out with 100 people and now has over 2,000 members. So I think the message here is that urban health is interest in urban health and evidence base for urban health has really been exploding over the last years. And I'm here as a clinical professor of global health and pediatrics at New York University, but also as chair of the board of the International Society for Urban Health, which is the only global nonprofit organization totally focused on urban health and urban health equity. So I'm going to give you a little background on urban health and then some examples of how cities are solving some of the most dramatic problems facing our planet in terms of health challenges. Just to contextualize urban health for you, I would argue that it's one of the 4 major public health challenges facing our world at this point in time, along with epidemiologic shifts. COVID notwithstanding, it's taken our eye off the ball a bit about the problems of chronic disease and chronic disease prevention as a major cause of morbidity, mortality globally. Demographic shifts into people having longer lifespans. This is a great public health victory. We often don't talk about it like that. It's always, oh my goodness, all these older people, how are we going to deal with them? But we really need to take advantage of that and really prepare our societies to manage support so people can be active as they age, active and have good quality of life. And then obviously anybody who's been in the UK, including me coming on the train yesterday from London, every 4th train seemed to be working, have experienced climate change very dramatically. And obviously this is even a much more serious problem in countries like Bangladesh, and others would have annual flooding that can eventually potentially eradicate major cities. So why do we get interested in cities? There's a bit of a debate over when this happened, probably 2007, 2009. The majority of the world's population live in cities, so that had to really be taken into account. And I think many of you who've been in global health development will realize that many of the paradigms of global health development are rural paradigms. And so many of that way of thinking, how do you scale up interventions? How do you deal with different environments? We saw, I think probably in the Ebola virus, the huge difference between the outbreak in historic outbreak actually in East Africa, which were managed quite well by public health authorities there in rural villages and areas, but then the outbreak in West Africa in cities, suburbs, people moving back and forth, really major set of challenges. So another reason we focus on cities is that even though they only occupy a small percentage of the world's landmass, they are really responsible for, they're really the engines of global development, both from an economic point of view, often culturally, communications-wise, due to their linkage to urban networks. And at the same time, that's the good news. The bad news is they also generate the majority of greenhouse gas emissions, use the majority of energy in the country, in the world, really, and generate global waste. So the message here is that you really cannot solve global health problems without solving the urban health problems and health problems in cities. So another reason cities are beginning to take more of a leadership role is they're kind of interesting to work with. Mayors are at the coalface, if you will, and their constituents are in their face as they run for office or as they try to manage. So as opposed to being at a regional or national level, we can be a little bit farther away from accountability. And many mayors have really organized when national governments could not do so. These are just some of the networks that are very active globally. And I think the message here is that politics and governance are very important in terms of progress in urban health. So one of the things I have to do when I talk to people about urban health in the United States is say, I am not talking about personal health care. I'm talking about health. And this diagram, which is from Wilkinson, Whitehead and others, Dahlgren and Whitehead, back in the 90s, really looking at what are the causes of health and health disparities. And we start in the center. We can change gender now, which we couldn't do when this diagram was generated, but these are sort of the basic and values and sort of basic constituents of our makeup as we're born. We're influenced by our families, individual lifestyle, and obviously the conditions in the communities in which we grow up. People who are poor have less access to some of the things we say. You want to have healthy food, you want to have good housing, you want to have good parks and green space, but if you don't have access to that, you really can't take advantage of it. So we have to change those environments. And then around the outside of the wheel are really the policies that are made by local, national, global organizations that shape the different sectors. And at the International Society for Urban Health, we've developed this diagram to really try to create a picture of what sectors have to be involved. And the message here obviously is the health sector in red is one of the ones that many of us come out of, both public health infrastructure and healthcare delivery. But the decisions made in all of these other sectors are very often much more influential on improving health and health determinants. So for example, if you have a transportation sector that tries to minimize the use of cars, you're having a huge positive impact on air pollution, on road traffic accidents, on other kinds of emergencies, and also on use of and effects on climate change. If the built environment in cities and urban planning is really looking at green space and availability of water, you're changing the dimensions around heat. Some of the things, London actually is one of the most resilient cities when it comes to and then looking at housing and economic development. These are all factors. And I would say 20 years ago, we didn't really have the evidence base to show that these changes make a difference in health. We now have it. And so anyone who's saying, well, there's always this soft and fuzzy public health, social determinant stuff, it's really much more serious than that. And in many instances, the evidence, and Arpana's been one of the leaders in Europe, the evidence is as strong as some of the clinical interventions that have become quite routine and are no longer questioned anymore. So the governance of cities, which is in one of the boxes here, is used as an approach called Health in All Policies. There's another workshop, I think, during this festival on learning about this issue. This has been around for about 30 years, thanks to our colleagues in Finland who've been writing about it. And I think the big shift, I'm going to call your attention to number one, which is that health and well-being is essential for overall social and economic development. And I think when this began to be seen, we didn't only think of the healthcare sector as a giant financial sinkhole. It was more of a cost center in a national budget. And so people thought, oh, we have to stay away from that. And now we begin to see that unless people are healthy, they can't work, they can't engage in communities, they can't pursue education, and they aren't involved in the areas of civil society. So with all of this effort going on, the SDGs, when they were developed, really did something quite dramatic, which was to look below the national level, which has not been the practice in UN agencies, and come up with SDG 11, which is the cities SDG, if you will. 3 is very familiar to this audience in health. I want to also raise in the context of this discussion 17, which is a really important SDG calling for partnerships in changing urban health. You've seen the multiple sectors that need to work together. This call for partnerships deals with the issue of civil society organizations as well as the business sector, which have been Those relationships have been historically problematic, but the UN has said if we can't bring private capital into solving global health problems, we won't make our goals. So this becomes very visible and important in cities as we move forward. So if we take a deeper look at SDG 11, you'll see, if you remember the bubble diagram, you'll see issues of housing, transportation, disaster preparedness, air quality, green spaces, et cetera, all are listed here. You will not see the word health in SDG 11 because health belongs to WHO, which is SDG 3. You will not see the word urban in SDG 3, but part of our job thinking about urban health is bringing these interests together and trying to cross historic territory, shall we say, in terms of integrating thinking about, and that's happening, to be fair, very importantly, between WHO and its sister agency, which is UN Habitat. This is something called a New Urban Agenda. And if you haven't thought about urban health much, this is now the global guidance on improving health in cities. It is much more focused, very focused on planning and housing and other really important pieces of urban infrastructure because that the UN Habitat Agency is kind of the planning and housing agency. But there's been enormously effective partnerships between WHO and UN Habitat more recently, and really beginning to putting out several volumes on something called the Blue Book, which was integrating UN Habitat and WHO approach to urban development, which is really important to look at. And last week, I think, or maybe 10 days ago now, the World Urban Forum was held in Poland. In spite of the environment in that part of the world, there were over 10,000 people attending in person. The meeting 3 years ago was in Abu Dhabi, which was about 15,000. So there are a lot of people. This would not have been an urban health conference. It's an urban conference, but there are a lot of health people. And I think in the early days, you had to find the 3 other people that were talking about urban health. And now they have booths and displays, and WHO had a quite important display. This is a really nice diagram that someone did looking at the interdependencies and interactions of the SDGs. And this is an urban health diagram, which shows you that, in effect, you need to work across all those government sectors, as well as with the private sector, civil society, as well as for-profit. So pause for a minute. I'm going to take a little bit of a deep dive into cities and how we think about improving urban health in cities. These are kind of the 4 characteristics that people in urban health research have been, the conceptual framework really they've been looking at for some time. And some of the original conceptual work give credit to David Blahoff and colleagues at New York Academy of Medicine, Sandro Galea, who's now the Dean of Public Health, and others that have really been using this conceptual framework to think about cities and to think about making change in cities. And the sort of takeaway of looking at density, diversity, complexity, and inequity, and again, this is a shift, is that everything that happens in cities isn't bad. All these things aren't bad. We actually learned a lot about density and COVID through some very important research that actually showed that density was a net advantage in cities in some of the areas in terms of tackling COVID. So let's look at each of these individually. This is the density issue. Obviously, population density is one thing, housing density, buildings density, these are all the kinds of densities. But in fact, the fastest growing cities in the world are cities around 250,000 to 500,000 in size. But the most visible cities are these great mega cities. So these are issues that we have to deal with, and it raises the issue of the challenge of informal settlements. To give a plug for the African Population Health and Research Center in Nairobi is doing some really important work about how do we measure what are the characteristics of informal settlements. So it's not a just, oh my goodness, conversation. It's like you've got to look at these pieces and see if these pieces are coming together. So that's very exciting. Diversity, this is a borough of Queens in the city of New York, has about 2.5 million people now. 138 languages spoken in the borough, many of these due to immigrant populations. You can imagine both the challenge this brings for the education sector and the public health sector, needing to tailor messages to different ethnic groups, different cultural beliefs, different activities, but it's a reason we live in cities, is the cultural diversity, the excitement, the richness of this arrangement. Complexity, this is a organization chart of the city of New York. I looked it up recently. Unfortunately, it hasn't changed very much. You can see, and if you did this for most cities in most countries, you would find the message here is verticality. We have put people in their stovepipes and their boxes and asked them to be specialists in a particular area. And the real challenge of management is how do you get mayors, political leaders who get the fact that these dots have to be connected to change urban health. And then our last area that's really important to keep in mind always is the issue of inequity. The saying, your zip code is a better predictor of your health than your genetic code. Michael Marmot gets credit for that. He's looked at this issue in London for probably 2 decades now, really talking about the inequities. And if you look at in the middle of the diagram, the 76 years and the 85 years, that's 4 subway stops in the city of New York along Fifth Avenue between Central Harlem, which is one of the poorest, not the poorest, but one of the poorest parts of New York City, and the Upper East Side, which is one of the richest. So there's a 9-year life expectancy difference in New York City right there. And the thing that I want to say about urban health is no researcher in urban health has to be reminded about health disparities or health inequities. It is in the DNA of anybody who picks up work in the urban setting. Often when you're talking to researchers, you have to say, what about the equity issue? What about the other issue? Oh yes, of course, we're going to do that. This is like embedded. And again, credit to Arpana and others for leading in this area for a very long time. So this is a diagram. It's not a city diagram, but I want to put it in here because again, it's the work of a Michael Marmot Commission for the Pan American Health Organization on health inequities, which was done 2 years ago, really. And I raise it because it's really important to realize that these structural drivers on the left-hand side, which you don't often see in diagrams, deal with the legacy of colonialization and colonialism and the structural issues of racism. These are beginning to come out really importantly in the urban conversation. I think a lot of the attention on COVID to the relatively certainly inequitable conditions in which so-called essential workers had to live in crowded housing, traveling on public transportation to get to their jobs, not able to work virtually at home. And we're also, because of our failure really to reach them with adequate healthcare and adequate preventive services, had certainly highly higher incidence of pre-existing conditions, chronic diseases, which make them more vulnerable to COVID. So these are also concepts that are very embedded in the urban health conversation. Another one, and each of those kind of contextual issues I gave you is kind of a conference in itself, but I wanted to, again, embed, this is the work of Sotiris Vardalakis. I wanted to put this up here with something called Healthy Polis, which kind of situates healthy, sustainable cities in the various areas of the built and natural environment discussion, which are really important to take on, and cities are in fact taking them on. So if we go back to this diagram, I just want to run through really quickly some of the things cities are doing to address these problems. This is not a talk about all the problems, but also they're working on them and making some really innovative interventions and changes. So one of the most visible has been the C40 Cities Network. This was created by Bloomberg funding back in the day. They have been very active in the Paris conversations when national governments were not able to do that. Networks of cities really, they're now 96 member cities in the C40, which represent over 700 million people on the globe. You can't read this, but these are the criteria for the LEED certification. I think a number of you people know about this. Is energy, one of the big problems in cities, and some of the over on the upper left, transportation is a big deal. Mobility is number one there. And then if you look on the right, you begin to see that this is really it was developed by the private sector, actually. The U.S. Green Building Council, and then has been adopted very widely and is adopted by architects, builders, and others now, and it has become a social marketing advantage. If you have we have a green building, we have a LEED building, LEED certified building. So it's been an important activity. This is a picture of something called by the Cool Cities Alliance, which I thought was very cool. I didn't know about this until I started teaching urban health. But the idea is you paint your roofs white or light gray. You don't do dark asphalt. You change the temperatures in cities. And this is something that's very doable, and many cities are adopting this work. Another advance in this area is called biophilic interior design and biophilic exterior design. Again, thinking about the aesthetics within buildings that remind one of nature, having windows, having water in buildings themselves, looking at forms, nest forms and other forms, business, wood and things that are more, and then how do people feel in their building? Is it a refuge or is it a good feeling to go? And we've had a lot of conversation about that during COVID, that's for sure, not wanting to go back. This biophilic, there's a biophilic index developed by Berto and colleagues. And the taller the building, the more you want to have green inside and outside. This is a picture from Singapore, high-rise residential co-op. This is from Mexico City. You can see they're really playing seriously about not only trying to get the roofs white, but getting the greens planted. Another area of digital cities. This is a connected city, picture of New York City. And we're seeing a lot of reference to smart cities, sustainable cities around the digital notion. And we start with buildings and move out. This is a frightening diagram to many leading cities. When I first started looking at it, I thought, what good is this? The foresight diagram starting in the UK. But the idea is you've got to have a systems approach if you're going to deal with these problems. And the green cover are the areas which are routinely collected for data by the physical activity, this International Physical Activity Survey. And then the darkness of the arrows is what comes into it and has the most influence. Left-hand side is how can we change the environment? Right-hand side is the people's attitudes and people's behaviors that need to change. And then finally, much more advances going on. This is International Association for Public Participation, looking at the stages of community engagement. And cities are really now very serious about this. And I think this has come in the last 5 years or so. We saw a lot of it in the Build Back Better, Build Back Fairer notions around COVID. We have to talk with cities at every stage, or with communities. What's the problem? What do we need to do to fix it? And then some final examples of, I think, really community engaged generated changes in cities. This is Ciclovia in Bogota, Colombia. This dates back to 1974. Many of us are now doing complete streets, healthy streets, closing streets for bikes and pedestrians and trying to increase active transport. Another Bogota example with the support of a very committed public health leader and also when he was mayor. On the right is a mass transit bus system, which basically co-opted a lot of the car jitneys, buses that were and had joint ownership of the bus system by those owners. It didn't put them out of business, it put them in a new business that was eco-friendly. And then on the left-hand side are the gondolas. This was planned from 2015, put in 2019. These are solar panels at the top of the gondola, which runs the gondola down from the slums of Bogota to the bus station into their work. And I would say there are 20,000 people a day using the gondola. So these are next steps. As I said, the UN Habitat is the implementing agency. However, the approach to urban is so important. We have a one UN approach to urban that's led by the Urban Secretary General. Every state, every country is being asked to develop a national urban policy. China and India have done so, which has been very helpful in terms of the political interest. Others are moving ahead with it. A number of African countries are working on the issue of urbanization. And these are important characteristics. We've touched on most of them. But the key is the importance of governance and political leadership and the importance of health in the other sectors. And then finally, the International Society for Urban Health, our international conference, is going to be held in October in Valencia, Spain. And glad to find out that there's a crew coming from Manchester. We invite you all to come. It's an in-person meeting. Actually, we'll be in person. There'll be very few virtuals. But anyway, we have to have you come learn more about ISUH on the social media. Thank you very much. you.
Hello, everybody, and sorry to disappoint you up front. There is no PowerPoint presentation for this short session here. Everybody loves PowerPoint presentation, like myself. These were great, by the way, these mornings, but otherwise, when technical people like myself speak on technical administrative subject matters, I can see in the faces normally people go, oh, another one with 23 slides. But for those of you who are real addicts, at 2 o'clock in room number E, there will be a PowerPoint presentation, and the topic is working for WHO, which I would personally extend to call it working for a UN organization. But for those of you who want to know more details and why I extend the topic, come to the presentation at 2. First of all, thanks for the invitation and congratulations to you in plural for the 10th anniversary of this very interesting event. And thanks to Aparna and her team also in that respect that I had to come to Manchester in order to meet again the two Joes. Like in a movie, in order of appearance, Joe 1 and Joe 2. And the funny thing is, I absolutely forgot. And I forgot that Joe and myself, Joe number 1, work in the same building, 1 floor apart. And it needs us to meet here. So thanks for the opportunity. And with Joe number 2, we found out this morning that we met already, not only this morning at the breakfast room, but also 10 years ago for the first time at the Global World Health Summit in Berlin, not to be mixed up with the WHO World Health Assembly, because that is the official organ authorized to put into legislation health measures across the spectrum that we cover. But the World Health Summit, not coincidentally with a similar title, aims to put together all the key players in global public health that there are, together with private corporations, in order to facilitate that what we often don't have or hadn't had before in form of a very one-dimensional box thinking and box approach. Of course, we in the UN, we always say we are happy to be one UN family composed of 25 organizations. I love you, brother and sister. But then when it comes to the details, oh, but we are different than you guys, yeah? But at the end of it, and I have been around for more than 25 years in 3 continents working for the UN, I would today say and dare to say the similarities are much greater than any discrepancies there are. And it has been a real phenomenal thing to see over the last 10 years, especially, that the common spirit of one UN family has really taken meaning. And we do work like this together with sister agencies, but also with collaborators outside. WHO wouldn't have the staff to address the magnitude of topics that we have to address these days. Wouldn't it be through the help and through the collaboration with over 1,000 collaborating partners, you guys being one and your university another one? Because while we have the data 24 by 24, 7 by 7, where we still need detailed research on topics. And because we can't have the time and the resources on standby, but we know where we have to go when we need a quick confirmation whether our impression is right or wrong, needs to be adjusted or what have you. Now, let me go a little bit into more details. It has actually been never a more exciting time to be in global public health than these last few years. My background is a different one. While I studied medicine and psychology, so I graduated in global clinical, cross-cultural clinical psychology. That's actually my focus point. I started with refugee agency UNHCR. Before that was an NGO in refugee camps in the Philippines. And over the time and 2 more agencies, I somehow came up to WHO then, where this background was not warranted, but maybe seen as could be helpful one day. When I was in Geneva first time working for UNHCR, the refugee agency, we looked across the street about a kilometer away and had the feeling, sorry, no offense here to Joe number 1, that WHO is a kind of old-fashioned status driven, lots of doctors, a little bit big and bureaucratic. My perception has changed, of course, since I'm there, but also the organization has changed dramatically, and I've been there 15 years now. And the last few years have seen an enormous hands-on approach to tackle the things from a multidisciplinary point of view. Now, this morning we had, this is a beauty that I see with my job, and I invite everybody of you to consider at least one stint with a UN agency. Because while I work for a mandate that I can totally associate with, meaning public goods in a non-for-profit organization, it is also that I personally enjoy being there, having the opportunity like this morning, and I have that all the time, to learn about new things that otherwise I would never have known about. We tackle about 1,000 medical and health-related issues, from very large ones to very small ones, and I learn about new ones every month. The large ones, of course, have been dominating the global world headlines these last 2 years. And when we had regular Zoom meetings for student visitor groups over the last 2 years, the typical question always first that came was, tell me, how is it working for WHO these days? It must be, the question implies that the expectation is headquarters must be like a beehive, everybody running around like mad, tackling this virus and saving mankind. And when I had to describe what I see in front of me, because I was one of the 20% constantly in the office during the COVID time while the rest was working from home, the absolute opposite was the case. And at 2 o'clock, I show you a photo of our empty lobby. That doesn't mean that we didn't work. We worked harder than ever before. One was the COVID thing. The other thing is, of course, you are the experts more than anybody else as an audience. Our role is sometimes more invisible than visible. We are the facilitators behind the scenes. We are the coordinator between governments. We are the executive secretariat to the owners of WHO, which is the global round of ministers of health. But the role is dual way. While we execute what the priorities of the Global Health Assembly are, we also feed into setting the agenda because we have the data. So it's a bit of a contradictory role, but that makes it so exciting. We see, we shape, we coordinate. And talking about the big challenge of the last 2 years, COVID dominated the global news. WHO at one point was on the news daily, basically around the world, sometimes on finance issues, sometimes on political issues, not in-house made, but from external sources. And luckily that was overcome. But the challenge for us was, how can we ensure that despite this attention and all the money seems to go into COVID area, we do continue to address the other elements? And that was a real big challenge for us. I think we managed so far very good. Dedication and willingness of staff to work overtime was absolutely unprecedented. And this morning we saw 2 programs where the success can be seen, especially in the polio area. A few setbacks, but that the setbacks are not bigger, I personally would say, is a great achievement in itself. We were 5 cases away from building up yet another metal structure in commemoration of an eradication of a disease. If you ever visited Geneva in front of the building, you find a few metal structures there in commemoration of this, smallpox eradication. Yeah, I was predicting we find one on polio very soon. I still hope so, that during my time before retirement we get there, but touch wood. But learning about new programs, as I mentioned, that's the exciting stuff. Typically in sessions that I normally do, which is working for WHO and showing you the back doors into the building that there are beside the official entry doors to the front. Pick for you to come later. That was that people asked me, how about WHO? My background is this or that, but WHO full of doctors or healthcare workers or whatever. Can I also work for them? And I remember a blatant mistake that I did at one session. It was in 2013. Normally you can. My answer is if your background is halfway legal, chances are you find somebody with your background. If not in WHO, then I bet my salary on it somewhere in the UN system. But then a hand raised up and said, I am a anthropologist. Now, do you have jobs in anthropology? And I was thinking, not that I know, and I'm in HR, so I should know. So blatantly wrong again, as it was not the only case, but no, mistakes happen and I can apologize. I said, probably not. And I was so wrong because it was weeks before the outbreak of the Ebola crisis in West Africa. And I recall that very intensively because, and this is typically WHO, and the challenge and the beauty of working there, it is not just a medical issue that we normally face. It was pretty quick for us to identify the bugger. The virus was known to us. Ever since the 60s, when a staff member who later worked for WHO and later in his life became Director General of UNAIDS in his student years, discovered in Congo, or was it Cameroon, I forgot, the Ebola virus. And in Berlin, where you and I were in one session, I recall how he described how he discovered it, just with gloves on. He didn't even know what he was dealing with. No mask, no nothing. He could be no longer there by now because it's a very deadly virus. Ever since then, and his name is Peter Pio, if you want to Google, very interesting guy. Ever since then, it was clear we knew what we had to deal with. But here I come to the anthropologist. It wasn't just a medical issue, as all these things are not unilateral. It is the combination of all and everything, including knowledge about the cultural habits in the area where it is spreading, including elements that we were seeing in terms of health distribution, social determinants of health this morning, and so on, that we were initially failing to address it in an optimal way. And in the end, we even shipped body bags there, I understand. And then when they arrived, they told us, oh my God, it's totally wrong here. I forgot which color, but incompatible with the local habits. It could be white or black or something. We got it wrong once again. And I would always call it thereafter, it was a 10-cent advice that a beginner in anthropology familiar with that region could have given us upfront to say, it is the social conditions that lead to the spread. And if you consider this, that, and that, then you are there where we were there with some delay. Just to show, yes, I wrap up, just to show, and this is a good wrap up sentence, it is the interdisciplinary approach that makes working in WHO, and I would say in other agencies as well, so enormously interesting. You don't stop. Allow me one more thing, 30 seconds, yet another story. The other day I learned about that we work on a program for prevention of drowning. Drowning, that's not really WHO, that's not public health, so much it is. I spent a high school year in the Philippines, school exchange. Beautiful country, 7,000 islands, things happen, and boats drown. And that is regularly, unfortunately, the case. But these islands are so close to each other, I would have thought in a country like this, everybody can swim. And the unfortunate thing is, often these people drown in view of the shore, because there are not big distances. So WHO started with this program, very little money involved, pilot program of mandatory swimming lesson introduction in primary school. It was so enormously successful with very little resources invested that we again tackled it multi-dimensional and we got results. So just an invitation for you, don't just think of health professions, you are, but WHO is a connecting point like the other agencies as well. Thank you very much for your attention and hope to see those at 2 o'clock who are interested in more.
Thank you, Hans. We listened to you for ages and good talk for this session. But can I ask Haylo? So Haylo, would you put the PowerPoint for me? Friends of the festival, Haylo and Louise, thank you for coming back. Over to you.
there is a lot going on in the world at the moment. And there are a lot of things that we don't have any control over.
With so much happening, how do we engage with those women who are vulnerable and who are isolated?
How do we give them the support that they need? How do we give voice to the unheard?
We don't have the answers, but we know that change comes with asking questions, and in doing so, we hope we can start conversations.
How do we support those women who might otherwise slip through the net?
Domestic violence is a huge issue in our society, but how do we change that?
Where do we start?
Outgoing, adventurous, optimistic. Glass is always half full, figuratively and literally. I like music, I like laughing, and I like eating Nutella straight from the jar with a spoon. That was my dating profile in 2010. That was before. That was when I was a human, when I was me. I guess this whole story starts with my dating disasters. Few people get the whole story. I suspect that that's true for many of us. What I mean is a lot of people might know your name, but they don't know your story. They might have heard what you've done, but they don't know what you've been through or how you feel, what you want. Anyway, back to 2010, my dating disasters. First, there was Kenny. I know, who's called Kenny? No. Kenny had these great big teeth, and I could see why he smiled with his mouth closed on his dating pictures. And then there was John, the hipster. John definitely fancied his own beard more than he fancied me. Still, we managed 2 dates, and then Marcus, and he repeatedly called me dude. Half a date, said I was going to the toilet, text him later, sorry dude. And then there was him. See, he was tall, he was dark, handsome, with beautiful teeth and sparkling eyes. And he had swiped right for me. Date after date with this perfect decorum, smiles, butterflies, blossoming, him, me, us. And then lockdown happened. And that's when things changed. I lost my job. And that was the first time that he hit me. But how could I speak out when the whole world was suffering? What did it matter if we had sex when he wanted, or we ate what he wanted when he said so? Who would care about such trivial things while the whole world was upside down? My mum came and she stood on the front lawn. She was 2 meters and a whole world away from me. Sorry, we can't have a hug, love, she says. Are you okay? She asks. Yes, I said. You see, my ego, it actually felt more bruised than my ribs. I wanted to let her in. I wanted to tell her everything, but I couldn't. I kept them out of reach. The ones who would notice the storm in my eyes, the silence in my voice, and the heaviness in my heart. The ones who I should let in, but who I couldn't. My issues were they were sinking into insignificance as the country crumbled around me. The country who's locked me in with this monster. And the death toll, it was so high. It made the bruises on my thighs look like little pinpricks. He watches the news obsessively. See who's here. That is what real suffering looks like. And he was right. And I was lost. When I saw the 2 lines appear on the pregnancy test, I felt physically sick. But then again, I had this glimmer of hope, new life, new love. I mean, surely becoming a father, that would change him. I truly believe that would change him. He had one of his outbursts and he started smashing up the baby's room, and I tried to stop him. Stop! Stop! But then his hands went round my throat and he was squeezing so tightly, and I was holding on to the baby and his eyes were just dark, and I wonder, are these eyes the last thing that I will ever see? Then the baby started crying, this ear-splitting cry, and his hands go slack, and I slumped to the floor, and I am gasping for breath. And I know then, I have to go. Go is such a simple word, and it is such an impossible thing to do. Go where? This last year, I've hardly seen another person. I've got no money. I've got no independence. I can imagine the stigma, the shame. Who needs me? Adding to their problems, like how could I possibly burden people at a time like this when so many people are suffering? So many people are struggling. And I feel this sadness. It's a sadness that you can't imagine, but it's one that you can taste. And I can still taste it now. It's like I'm sitting on a hill and I'm looking out into the distance.
But I can't see the view. You see, this mist, it blurs my vision. It has made me so unobservant, so blind to the support that is out there, that is so close at hand within my community. It's blurred the things on the horizon, and I can't see it now. My lonely heart can't see that now. I might not seem like a victim or look like a victim, although I'm really unsure of how that's supposed to look. I mean, I don't have bruises or hide away, but he was violent, just not with his fists. I've always been independent, headstrong, and if I must admit, a little bit stubborn. People would say that I wore the trousers in our relationship. I mean, what a ridiculous statement. I'm really unsure of when the cracks started to appear in our relationship, or when the world that I existed in, it existed in this constant state of dread, and I'm unsure of when my confident demeanour, it just turned into a facade. And by the time I actually realised what was happening, I'd completely lost control of who I was. And I suppose when you're in a relationship, you lose your identity, you believe those lies. I mean, that's what happened to me anyway. I completely lost the ability to believe that I could live independently. And dread, it can start off very small, and you can pretend not to hear it. and then it gets louder and louder, and it is really difficult to ignore. You see, with him, it was the little things, a lot of little things, and his actions versus his words, they created this further discourse. And he knew exactly what to say, and I had invested a lot in him, in us, in our relationship, and I felt like I had to hang on to that. I mean, that's how he made it seem. I had to. He was always confusing my thoughts, telling me that I was wrong, that I was making things up. I can't find my keys. I can't remember my passwords. My emails were disappearing. My thoughts are muddled, unstable, unable to think. I shouldn't have done that. Why did I do that? I'm sorry. I'm sorry. But I actually don't know what for. I never knew what was going to set him off. I felt like I was walking on eggshells, the scattered remains of my hope just crunching under my feet. And now I don't actually recognize the person that I've become.
I feel like I am stood on the outside of something. My hands up against some foggy glass.
A swirling mass of confusion and anger, shrouded by this dull, uncertain feeling, swamped by this cloak of doubt and darkness.
Knowing that this shouldn't be happening, but not knowing how to admit it.
How can we be heard?
How can we be helped?
There is a lot going on in the world at the moment, and a lot of things that are out of our control.
But our right to be heard and our right to be supported should never be out of our control.
What have we learned in these last few years? And what can we do from what we have learned?
How do we give a voice to the marginalised?
How do we start these conversations?
How can we be heard? How can we be supported?
How do we end violence against children and women?
We don't have the answers, but we know that change comes with asking questions. Thank you.
Thank you. We are Haylo Theatre with Hayley and Louise. We write and perform all of our own work, and we do so from real stories and experiences that people share with us.
We use theatre as a way to engage with difficult topics and subjects, and to give those subjects sort of an emotive human face that people can connect with and resonate with. Yeah.
Thank you. Thank you for having us.
Go get to your parallel step. Please do get to your programs to find out where you need to be. I see you back at the virtual plenary. Thank you.
No, we're done. We're done. We're done. No, we're done.
Were you saying Yeah, exactly. Late, it's like 8. Oh, yeah, okay. That's when I